Hi everybody, my name is Kevin O'Brien and this is the YR World webinar series. Sorry, the YR World webinars, and we are delighted to be joined here today by Emmanuel Olamijuwon. I hope I pronounced that right. And Emmanuel is joining us from Eswatini, which is formerly known as Swaziland, a country in Southern Africa. And as the title says there, uncovering the demographic data dynamics of COVID-19 cases and deaths using R. Before we begin, I'd like to thank our sponsors, Jumping Rivers, who provide ongoing support to YR for our webinars, and also their ongoing support to our user groups and events around the world on an ongoing basis over the last few years. If you're joining us, please say hello in the chat. We're delighted to find out where everyone's coming from. This is an unusual time session, so maybe not as many people as usual will be watching us, but please say hello. And to all of our user groups around the world who might be joining us, please also say hello as well. If you have any questions, just drop them in the chat and we'll answer them at the end. But apart from that, I think we'll hand over to Emmanuel. Emmanuel, we'll let you go there.
Thank you so much, Kelvin, for the introduction. So just to give a background, my name is Emmanuel Olamijuwon. I'm from Nigeria. I think of myself as a Pan-African because I'm from Nigeria. I'm doing my PhD in demography at the University of Witwatersrand, and now I'm in Eswatini, where I used to be a lecturer in demography and statistics and demography. So this presentation is part of a project which I'm working on. It's the COVe, and it's a database that includes international data set about age, sex distribution of COVID-19 cases and deaths globally. And that's what we will be talking about and how to do this analysis in R. Just to also add that I'm also a co-organizer of the Estwatini user group, which is a user group also for building local capacity using R in Eswatini. So that's that about me. Kelvin, do I go on to the presentation?
You're good to go there. I think you can just work away there. Looks good.
Great. Thank you. So the outline of my presentation is that at the beginning, I'll take you through the COVID-19 pandemic and trends with special interest on Eswatini, and also give a demographic perspective of COVID-19, what's motivating this presentation, and also the coverage DB database that I hope that will be useful for you or anyone who's doing this kind of research, maybe in demography, and also looking at how this database can be used to uncover demographic dynamics of COVID-19 cases and deaths. Just to also add that you will find that most part of my presentation does not really include codes, although I have a few codes, line of codes there. But at the end of the presentation, I plan to discuss, I'll share my R Markdown sheet for reproducing some of these analysis. So as we might all know, so the COVID-19, the first case of coronavirus was confirmed in China around December 2019. And by 14 February, the first case was confirmed in Egypt, in Africa, and subsequently we also confirmed a case in sub-Saharan Africa in Nigeria around 22nd February. But by 5th March, the first case of coronavirus was confirmed in the Southern African region, precisely in South Africa. And by 11 March, the World Health Organization declares the COVID-19 a pandemic. And this was after a case has been confirmed in almost all countries and precisely also in almost all continents. By 20th March, death toll from COVID-19 has already reached 10,000 globally. So all countries in total have experienced about 10,000 deaths from COVID-19. And by 14 March in 2020, we recorded the first case of coronavirus in Eswatini. And by 27 March, the country implemented the first, called a partial lockdown, but this was also after South Africa implemented our own lockdown. So this lockdown meant that people could still do basic activities, but it's partial because international travels are restricted, and there's also a limit to what you can do. You have to get a permit to do to access basic services like even shopping and many other things. By 16 April, Eswatini recorded our first death from coronavirus. So yeah, I tried to give a picture of where we're coming from the beginning of the first COVID-19 globally and to when the first case was identified in Eswatini in 14 March and 16 April. That's about 1 month after Eswatini recorded the first death from coronavirus. And here I also present the incidence of coronavirus in Eswatini, so the number of new cases in Eswatini. But the most striking thing here is that in January 2021, just this year, between January 1st and 31st, we realized that the total number of cases confirmed in Eswatini during that month alone is more than the number of cases confirmed from March till December 2020. And that's, I mean, a lot of factors could have driven that. It was a period of festive, and we also know that a lot of people from Eswatini work from neighboring countries like South Africa, and so they could have traveled from South Africa to Eswatini, or even from neighboring countries like Malawi, Mozambique, and several others. And also maybe people who are also returning from these countries to Eswatini in January. So we saw this huge spike in cases confirmed in Eswatini, but also mortality was also very high during this period. As at 29 April, as at March, what is this now? As at March 29, 2021, this is March 21, 2021, the number of cases confirmed in Eswatini is now 17,337. But I also understand that as of yesterday, there are about 39 active cases from coronavirus, and only 3 of them are hospitalized. So we have very few active cases right now, and we hope that that remains stable for a while. But what is most interesting is, what is most interesting to everyone, and I think what is most striking across the world is the level of mortality from COVID-19. On one side, people are looking at, everyone is looking at how many dead, why is there so many dead in this country compared to that country? But one way that we've also been making comparison is using the case fatality rate. So how many new deaths, or how many deaths in total from the number of cases have been observed across countries. And in this chart, I try to present case fatality rate across the world, first for July 2020, and then subsequently after by December 2020. And I compare these trends. And the reason why I compare these trends is because in some way, looking at July 2020 might be tricky, because this was this was just a few months from the time that the first case of coronavirus was confirmed in African countries. So we don't expect so much fatality from African countries during this period. But again, I also compare this period with December 2020. And what I find from the first chart is that a lot of the fatality from COVID-19 from Yemen, Belgium, Italy, Hungary, Mexico, Spain, and several others, mostly in European countries. But what is striking is that we have very few case fatality in African countries. Chad, for example, has a case fatality rate of about 8 deaths per 1,000 cases. Sudan, Liberia, and the Republic of Niger all have cases, all have deaths, about 6 deaths, about 1,000 cases. But I mean, I feel like case fatality rate for Chad could have been a little bit high because of also the population of Chad. So that could have also influenced the high level of fatality. But looking at the rest of the African countries, you see that it's just about 6 compared to 14 deaths per 1,000 cases in Belgium, 14 deaths per 1,000 cases in Italy, and Hungary and Spain and several others. And by December 2020, you also see that this pattern still remains not so much changed. In Egypt, which is an African country, we are starting to see a few more African countries rising to the top 15. So here I'm just showing the distribution of countries with the highest fatality rate from COVID-19. And you still see that these countries, Syria, Mexico, and a few, very few European countries now are in the highest case fatality rate by December, maybe due to the management. But we still see very few African countries compared to these other countries. For example, in July 2020, I took a closer look at Eswatini to look at what was the case fatality rate in Eswatini. And I see there that in Eswatini, it's just about 1 death to 1,000 cases. And that's very little compared to 14 deaths per 1,000 cases in Belgium, compared to 14 deaths per 14.2 deaths per 1,000 cases in Italy. And what has been on everyone's mind has been, why is there so little case fatality rate in African countries, especially in Eswatini? And I've seen a lot of discussions around this debate. On one side, it's about what is African countries doing differently. How can world leaders learn from African countries? And I don't think these are really bad. I mean, they are great ideas. It's important to learn from the best. But another question that everyone else is asking, or even demographers, is that, is it really that Africa is doing something different, or there's something special about the demographics of Eswatini that makes it experience very little fatality? But you also get a lot of news coverage about the magic mixture, maybe like an herbal mixture, maybe vaccine, a local vaccine. We've seen a lot of that. There's also maybe concern about maybe Africans being immune to the virus, coronavirus, which may also be leading to fewer deaths. There are also been reports about there have also been reports about the weather in African countries. Maybe the weather is favorable, so fewer persons get it, and maybe fewer persons die as a result. And so all of these have generated interesting and diverse perspectives. And this is also where demographers come in. And just to give a background, so what demography is all about is studying human population. And this has to do with the size, the composition, the distribution, density, growth, and all of these other characteristics, and how all of these affect the consequences, and how this affects population, and also it affects population change and population health and well-being. And when we're looking about population composition, we're looking at how the population is composed in terms of age and sex, how many males, how many females, how many young persons, how many older persons. You also want to know how the population is distributed, how many persons are in the cities where maybe there's overcrowding, how many persons are in the rural areas, how are the cities distributed, what's the rate of growth, among several others. And how our researchers in demography have applied this perspective is such that on one side, there has been a perspective about maybe the age structure of African population, or let's say in general, our age structure of population might explain differences in fatality rate across countries. So basically, we know that African countries have a huge young population. There are very high number of persons in the younger age group. Whereas in European countries, we know that there is a lot of elderly population. So it's a lot of elderly persons in the population. And this perspective is driven by research that have shown that age is related to fertility. So you expect more deaths from the older population. So that's one perspective. But again, there's also been another perspective to say, fine, the country can have a young population, but if the young population is not infected with coronavirus, they won't die. If the older population of the country is the one which is being infected with coronavirus, they are the ones that are going to die. And this is what, and that's what I call the doodle perspective. So they basically refer to it as that the age structure of detected cases in the country would possibly explain the fatality from the virus. So how persons that get the virus are distributed along age. So if we expect that if a lot of older population in Europe are getting infected from COVID-19, then you expect more deaths from that country. So that's one perspective which I call the doodle perspective. And I think it's the one that I'll talk a little bit more in the later part of the presentation. There is also perspective about differences in age structure that puts countries at different risk. Age structure, for example, and this is basically in terms of that countries with very young population might be maybe more mobile, where people also move. Maybe countries in older population, maybe you want to take into consideration the elderly home. And I think that's also what drove the lockdown, especially in care homes in France. And so that is what led, so the idea from the doodle perspective is what led to the coverage DB. And just if I can mention, so the coverage DB is a database that has information about the age, sex distribution of cases and deaths globally. So it's an international volunteer collaboration that's coordinated by the Max Planck Institute for Demographic Research in Germany. And there are about, in fact, there are more than 60 researchers on this project. And here I present the preprints for the project and all authors who are on the project. And I think it's also still open to anyone. If you are interested, feel free to send an email and you'll be included on the project. So it's an international volunteer collaboration that is coordinated at the Max Planck Institute, like I mentioned. It includes database for almost all countries in the world. Including South Africa, and including the ones in African countries. Even though we have seen a little bit of resistance at the beginning of the pandemic, where there were very few African countries sharing the data, but we've also starting to see many more countries, and we are even also starting to collect data on vaccination. So what is vaccination coverage look like across age and sex. Another thing is that this database includes time series since March, and in fact, for some countries, we have time series since February, and we've been collecting this information consistently since then. So we have data about age sex distribution of COVID-19 for every day in March, every day in April, May, June, July, August, provided that these are published by the Department of Health or any organization, any government organization responsible for that. So like I also mentioned, we use data from various sources, mostly from the Department of Health. Some of the measures are also harmonized such that we have an harmonized age structure. Some countries are reporting the figures in different ways. Maybe in some countries it's in 5 years, in other countries it's 10 years. So we use a kind of standardized measure to harmonize these measures. And here I present a kind of geographical distribution of coverage, and you would find a lot more information about this on GitHub. But what you see is that we've tried to cover a lot of African countries. I think Southern Africa is well covered, except for Zimbabwe and maybe Mozambique. But you also see that we have a large coverage even in the West African countries, in the United States, and also in many European countries. And just below the chart, I present an R code for downloading this data in R. So if you would like to play with the data set, you can also always do that using this package. So it's a package created by a colleague who developed the package for Coverage DB. So you have to develop, you have to install the package first using DevTools and install directly from GitHub, and then you can collect data for any country. Here I demonstrate an example for Eswatini or Italy, but you can also do it for any country provided that the data is available. So based on what we have seen from Doodle's perspective about age distribution, so what I did was that I tried to create a population pyramid. So we call it a population pyramid because it shows on one side the sex distribution, and the other side also shows the age distribution. And what you see is that in Eswatini, for example, a lot of the confirmed cases in Eswatini are mostly around the 20 to 49 age group, 20 to 49 age group, whereas you have very few cases in the older age groups. I mean, from 60 and above, you start to see very few cases. And that's in contrast to what you see in Italy. For example, you still see that a lot of the cases are still in the older age group compared to what you observe in Africa, in Eswatini. But you also still see that a lot of the fatality in Italy is also in the older age group, and I think that's quite expected because there's a large population that's infected in that age group. And by the time that, for the period that I was considering, which is 29 December, you'd see that the case fatality rate for the two countries kind of differ. It's almost like twice in Italy compared to Eswatini. So Eswatini had a case fatality rate of about 19, or let's say 20 deaths per 1,000 cases compared to about 35 deaths per 1,000 cases. But you also see that the age distribution is entirely different. So in Eswatini, the proportion of cases in the older ages, so from 60 and above, is just about 9%, and that's in contrast to about 28% in Italy. But that's not enough for me to make, that's not enough to make an informed decision, right? And yeah, what I did was that I tried to model this. So for example, we're looking at age distribution of confirmed cases on the one side, and also looking at age distribution of deaths on the other side. And here what you see is just typical from what I presented in the population pyramid. However, you see that a large percentage of the population that's infected with, or that's got the virus or confirmed in Eswatini is in the age group 30 to 39. And that's in contrast to what I explained earlier. So for example, Italy, the largest proportion is in the age group 50 to 59. But you also see that from that age group from 50 to 59, the proportion is so wide compared to what you see in Eswatini. And again, when you look at the age-specific fatality rate, you see that a lot of the deaths in Eswatini is happening from age group 70 and above, right? A lot of the death in Eswatini is happening from age 70 and above. But you also see that the number of cases in that age group is so little. There are just very few persons. So if a lot of people are dying in that age group, you expect, I mean, if it's 90% of deaths in that age group, and there are just 20 persons in that age group, that's just about 18 deaths. Compared to for Italy, for example, you also see that age-specific fatality rate in Italy is also high in this age group, but that's in contrast to this proportion of the population in Italy. So that's taking us in one way a step closer to where we're going with the doodle perspective, to say that maybe the age structure of the confirmed cases might be driving this pattern. And again, so one approach that we use in demography, I mean, especially for comparison, I mean, on one side, it's you can say that case fatality is high in Italy compared to in Eswatini. But one question that someone maybe in demography will ask is that, but these countries did not have the same age distribution. So what if Eswatini had the same population structure of confirmed cases as Italy? So let's say we get, so let's say in Eswatini, let's say we get this similar pattern of age distribution of confirmed cases. What will the mortality look like based on what we know about this trend? Would mortality be so high in Eswatini compared to what is observed in Italy, or it will still be so low? And on another side, you can also ask again that if Italy follows the same age structure as Eswatini, so if Italy had this population structure, can we expect that mortality in Italy would have been lower than we observed? And I feel like this is important, especially for policy, if we know that confining young persons, for example, or maybe confining other population can be helpful in curtailing the spread of the pandemic, then we might just want to do that. And that's what I try to do in this, in the subsequent slide. So I try to look at it to say, if we follow the age pattern of confirmed cases in Italy, would we still have this high number of case fatality rate that we experienced in Eswatini, or it will be lower? And so that's basically called the direct standardization method. And the code for generating that, it's using this. Of course, it might be difficult to follow, given that maybe you don't know how I generated the deaths exit, but I will take you through that process at the end of the presentation. So here I present a table. It's a table from COVe DB, like I mentioned. On the one side, we have the distribution of cases in Eswatini. We also have the distribution of cases in Italy. You see that the distribution of cases is not the same. Italy had a large population, a much larger population compared to Eswatini. The distribution of deaths in Eswatini, we have just very few deaths in Eswatini, just about a little above 300 deaths about this time. And then I also have the age-specific fatality rate, which is basically the number of deaths divided by the number of cases in each age group. So how many deaths per case, how many deaths per cases in each age group. So it's a within age group estimation. And what I observed from that approach, I mean, this is just a basic approach. There are more sophisticated demographic methods for doing this kind of comparison, but also for ease of understanding, I chose this. So what I find is that so case fatality rate in Eswatini was about it was about 19, if I remember correctly, it was about 19 deaths to 1,000 cases. But I see that if we had followed the same pattern as Italy, right? If we followed the same age structure of confirmed cases, so if we had a lot of confirmed cases in the older population, we would have experienced like twice, in fact, about 3 times more deaths than was experienced in Eswatini. So if we had the same structure of confirmed cases, then mortality would have been very high in Eswatini. And it looks like that was our saving grace. Maybe all of these other explanations could have been, I mean, they are obviously very valuable, but it looks like if we had more persons, more confirmed cases in the older age group, then the fatality would have been very high. And I also repeat that same process also for Italy. So for example, if Italy had the same distribution of confirmed cases as Eswatini, what is the level of mortality that we can expect in Italy? Would it have been lower? Would it have been higher? And what I observed is that, so on one side, it's the observed case fatality rate. So we observed, based on the distribution of cases and deaths in Eswatini, in Italy, we observed that there are about 34 deaths per 1,000 cases. But if we follow the age distribution of confirmed cases that was observed in Eswatini, Italy would have had about 7 deaths per 1,000 cases, far less deaths compared to what was observed. So it looks like, if I'm to interpret these two measures, it looks like Eswatini had fewer deaths because a lot of those who are diagnosed positive of the virus were in the younger ages. So, I mean, as a result of immunity and a lot of other factors. Whereas Italy had a lot of mortality because a lot of the confirmed cases are in the older age group. Whereas if there have been more confirmed cases in the younger population, then we would have expected far less death, about 7 deaths to 1,000 cases in Italy. Another approach is to also, so on one side, I took the population distribution of confirmed cases in Eswatini and try and see, and okay, I took the age-specific fatality rate in Italy and modeled that based on population distribution of Eswatini to say that if Italy follows the population distribution of Italy, what would it experience? But again, you can also do it the other way, such that you can say, if Eswatini had the same mortality pattern as Italy, so if we had a lot of death in Italy, like is observed, what would be the level of mortality in Italy, right, or in Eswatini? And so the first two, the middle aspect, so the blue part of the graph is the one that shows the Eswatini distribution, and the black part of the graph is the one that shows for Italy. So these two are just indicating the observed fatality rate. So in Italy, for example, we observed about 35 deaths per 1,000 cases, whereas for Eswatini, we observed 12 deaths per 1,000 cases. Whereas if Italy had observed the same age pattern of confirmed cases as Eswatini, Italy would have had 7 deaths per 1,000 cases, right? And if Italy also had the same mortality pattern as Eswatini, so if people die in Italy the same way that they died, I mean, in terms of age distribution, Italy would have had 13 deaths per 1,000 cases. And these two comparison, right, they are far less than what was observed in Italy. And that's quite interesting for me. And again, if we also look at Eswatini on the other side, so if Eswatini had the same mortality experience as Italy, so if people die within the age groups the same way that they die in Italy, how many deaths can we expect to see in Eswatini? And I find that we would have found about 96 deaths per 1,000 cases if Eswatini had the same mortality pattern in terms of age as Italy. And if Eswatini followed the same age structure of confirmed cases as Italy, Eswatini would have had 53 deaths per 1,000 cases. In all of this, what I observed is that if we adjust for age distribution, Eswatini would have had far more deaths than is observed in Italy, than is observed if we adjust for age distribution in Italy, if we adjust for age distribution of mortality also in Italy, Eswatini would have had far more than. And based on all of that, it looks to me like age structure of confirmed cases may have actually explained these differences in fatality rate between Italy and Eswatini. And I think this is quite an interesting point. I mean, it's also relevant in curtailing future pandemics, to say maybe in the future, and I don't think this is a new finding. This is something that is consistently being shown in previous stories, but it kind of also highlight the importance of Department of Health or government department to release this kind of data for more analysis like we are showing here, to also emphasize the importance of age distribution of cases or even age distribution of death. And it also, I mean, from the policy perspective, as much as possible in such circumstances, maybe we just want to protect the elderly population from being infected. And that could mean that we do this as early as possible. It could also be in terms of restricting movement to these elderly homes, like I think France did earlier on in the pandemic. So that's the summary of all of this talk and how we try to use coverage TV to show all of these patterns in age distribution of confirmed cases. But I also think it's important to highlight a few caveats. So this is just an interesting perspective, and it's a very descriptive and a very basic analysis, like I mentioned. But it's also important to highlight that so we reported, right? So we reported case fatality rate based on the number of cases divided by the number of deaths. But that's also conditioned on being able to identify, being able to accurately identify cases. So if countries are not able to identify cases effectively, diagnose cases effectively, then would maybe fatality rate could have been overestimated or underestimated. Case fatality rate could have been overestimated or underestimated. And this might be, this could have been driven by a lot of factors. Could be driven by testing protocols. So in some countries, I know that in Eswatini, you can't test until you follow a set of conditions, right? And this might be different in other countries. So maybe in some countries, they're practicing mass testing. So they're able to identify a lot of cases. Whereas maybe in other countries, it's based on a set of stringent conditions such that in the end, maybe those who will be tested or maybe those who will be diagnosed will eventually die. So that is one caveat that I think is important to take note. But even these caveats are well noted in the coverage DB. So we have a section about metadata. So as much as you also try to engage with the data, it's also important to keep these caveats in mind and also read documentation about what's collected and what's reported at the national level. I also think that the findings are descriptive and may be interpreted as case fatality rate that is conditioned on being diagnosed positive. So rather than CFR in the general population. And I think that's related to my first caveat that I mentioned. So it's based on being diagnosed. So I might be asymptomatic, I might be living with the virus, but maybe not showing a lot of symptoms and may have been missed from the denominator for that calculation. Another thing to also note is that countries were at different levels of the pandemic. So there are perspective that African countries may have experienced low fatality rate because maybe we have a new understanding of how to manage the pandemic. By the time that cases were identified in African countries compared to earlier on in the pandemic. So maybe more fatality would have been expected for among countries where the cases were first reported compared to where cases were identified later on in the pandemic. But again, I tried to use data for December. But again, we also know the effect of the cumulative effect of these things. Another thing is that population distribution, underlying health system also play a vital role in diagnosis and also, it plays a role in diagnosis and who eventually dies. So in countries with poor health management system, we expect that maybe there will be more mortality from the virus compared to with more sophisticated system, or even also has to do with the burden on health system. So maybe the burden of health system could also determine the level of fatality. But in all of these, I think it's interesting to extend the doodle approach to maybe also identify more factors. What I have tried to do is to look at the key aspect of demography, which is age and sex. And this is the key aspect of demography. This is all that we do, looking at how age sex distribution affect a lot of things in the population. So I think it will also be interesting to extend this approach. It would be interesting to compare the trend as at December 2020 to now to see if anything has changed in terms of age distribution. There are so many things that we can think of and talk about. So here's a GitHub repository for the database. If you would like to know more about the coverage DB, you can feel free to send an email. You can engage with the GitHub. The GitHub has a lot of information. There's a Shiny app that shows information about what's available, what's collected, dates for which data is available. There are these frequent updates. If you would like to get involved in the project, maybe you observe that maybe data has been reported for your country and you see that we haven't been able to capture that in coverage, you can always send an email and we'll be happy to include that in the database, or you could also join the team as a collaborator on the project. Yeah, so thank you. I'd like to say thank you to YR for this opportunity to share this work. Thank you to Eswatini user for inviting me to join the leadership team. It's a great pleasure. University of Witwatersrand, where I'm doing my PhD, and you can always engage with me via my email or Twitter. I also write blogs. I'm starting to write blogs on R, so most of the things that I write might be much more interesting to someone who is starting with to use R. But yeah, if you would like to write, I think I'm also open to having external writers on the blog. So the last part is where I can take you through the R code if you are interested. So some packages that I love to use tidyverse a lot. Cable extra for displaying my tables. It gives a nice fancy for table, and then show tests for showing fonts. Yeah. So there's my computer is filtering. Maybe I have to stop
Take
the
a second
presentation.
there, yeah.
Yeah, I have to stop the presentation.
Yeah. I tell you what, we can. Yeah, it's back now, so it's working again.
Okay. Oh yeah. So okay, just a moment. I think I have to stop my presentation first. I missed that part. Yeah. Yeah. And then this is actually quite strange, but
I tell you
just
what. Okay, sorry, go on, yeah.
okay, I think I'm not able to share. Oh, now it works well.
Yeah,
Oh,
not to worry.
this is quite strange, but I mean, I think we can keep an eye on my webpage. I plan to share these resources on my webpage. If you think they will be useful, I think it would be nice to check back. Oh yeah, and I think it's back again. So these are a few packages that I use: tidyverse, extra font, cable extra for displaying tables. And one way to load the coverage DB in R is using the COVID data. Um, this is actually quite strange. I don't know why this is happening.
I tell you what, we'll leave it, will we? It just goes, it flickers on and off, so we can just read it out.
We can just.
Yeah, we could talk about it. If we can't share it, the screen just goes black. So if we can't share it, let's not worry about it. So you can just stop the sharing there. We can have a chat. Stop participant sharing. Now, are we there? Hello? Oh dear, I think we've lost our guest. So we'll just give it a moment there. Folks, unfortunately, it looks like we've lost our guest. We'll just give him a moment to sort of log back in. But if you just bear with us there, we'll be able to ask some questions. So, our guest is joining us from Eswatini, which is in Southern Africa. He, in advance of the presentation, he sort of expressed hope that there would be no issues with internet, but unfortunately, I think that is actually what has happened here. We have had internet access issues, and in that case, we won't be able to proceed with the questions and answers. But I'd just like to thank everyone who has joined us from around the world. From Eswatini, I see you all there in the Q&A section. Also, people who are joining us from Senegal and Mexico. So thank you for joining us as well. Now, I'll just sort of see if he is coming back. Unfortunately, he's not coming back. So essentially, I will direct everyone to the Eswatini R user group on Twitter. Eswatini user, I believe, is the Twitter handle, and that is that we could take up the conversation there. I'm very grateful for everyone from Eswatini, both Emmanuel and all of our user group there, who are stepping up a bit and joining the world stage, and overcoming challenges like obviously COVID crisis and internet connectivity, just to be sort of make sure that they are part of the global or community. So, folks, unfortunately, I think we'll have to leave it there. And I thank you everyone for joining us. And hopefully we'll be able to sort of follow up with this conversation and see where the how things are going with the Eswatini or user group in the future. So unfortunately, I'm going to end the transmission there and end the live stream. Thanks, everyone. Okay. And also thank to our sponsors, our Jumping Rivers. So we'll leave it there. Thank you very much, folks.